Welcome to this Brookings event examining the possible policy implications of the election on social determinants of health. I'm Stuart Butler. I'm a senior fellow here at the Brookings Institution. And this event is supported by the Robert Wood Johnson Foundation. First, a definition. By social determinants of health, we mean those non-medical conditions in the places where people live or work that influence their health. So that's things like transportation, nutrition, housing conditions, also stress in a community, even cultural and language barriers that can impede good care. Now we know that for social determinants to be addressed effectively, people, institutions, and programs in different sectors must work together. That can be a challenge, and public policy can either help or hinder that collaboration. In recent years, we've seen a variety of policy actions to address social determinants and enhance collaboration. One area has been administrative action by the federal government. For example, there have been pilots undertaken by the Departments of Housing and Urban Development and HHS that have coordinated housing and health services for the elderly. The federal government has also used its Medicaid Waiver authority to address social determinants. For example, allowing a North Carolina pilot that coordinates housing, food, transportation, etc. for high-cost, high-risk Medicaid beneficiaries. A second area of action is legislation. For example, Congress has widened the benefits available through Medicare Advantage plans to things well beyond strictly medical care. You may have seen the ads emphasizing you can get trips to appointments and meals and so on through Medicare Advantage. And there's other legislation in the pipeline in Congress. And third, states and local governments have been active. For example, more than half the states now have so-called children's cabinets, which allow different departments to coordinate a whole range of things that affect the health and performance of children. And cities and counties have helped organize a number of public-private efforts within communities. So a lot's been going on. Well, soon we'll have a new president, a new Congress, a new leadership in several states, counties, and cities. So how will that affect federal action in the future? What about action at the state and local level? What about legislation in the pipeline? Will that be stalled, or will it be more likely to pass? Well, we have an excellent panel today to answer those questions and other questions that you have about how the election might change policies and the momentum for social determinants of health. I'm going to briefly introduce each panelist and then ask them to take a few minutes each to give their take on where we're going and in terms of advancing social determinants of health strategies. I'll also ask them to read the tea leaves on what they think will happen from a Biden administration, the Congress, as well as other things around the country. And then we will open it up for your questions. But before I do that, let me explain a couple of the housekeeping rules in terms of how we're going to use Zoom for this webinar. First, if you can, please rename yourself if necessary with the format of first name, last name, and affiliation. That just helps us to know who's on the webinar. Second, if you have a question during the webinar, please use the Q&A box at the bottom of your screen. That will let panelists and me see the questions that you pose. And I should just emphasize that you can post a question at any time. Third, please use the chat function only for commenting on the discussion among yourselves, not for asking questions of the panelists. And fourth, please don't use the raise hand function. We won't be enabling speaking capabilities for attendees during this webinar. As I've said, please use the Q&A only for questions. I also want to let you know that we're recording this meeting, and the recording will be added to our Building Healthy Neighborhoods webpage at the Brookings Institution. The link will also be sent out to everyone who RSVP'd, so you'll be able to see this later. So now let's go to the panel, and please start thinking about your questions. First, we have Melissa Quick. Melissa is co-chair of Aligning for Health. That's a social determinants of health advocacy organization focused on advancing policy solutions to address social determinants of health. In this role, Melissa has works closely with governments at all levels and the private sector to develop and promote cross-sector solutions to address health and social needs. Melissa is also vice president at Sorona Strategies, a healthcare consulting firm based in Washington, D.C. And prior to joining Sorona, Melissa spent 5 years at the Centers for Medicare and Medicaid Services, CMS. In addition, we have Kavita Patel, and there's an interesting story about Kavita. Kavita is at Mary's Center, which has just had a fire alarm warning. And so she's trying to find a space to tune in, and hopefully she'll be able to do that at some point early on in this webinar. Kavita is a non-resident fellow here at Brookings, and she's also a primary care physician at Mary's Center, which is a federally qualified health clinic system in the DC area. Kavita served in the Obama administration as Director of Policy for the Office of Intergovernmental Affairs and Public Engagement in the White House. And she was Deputy Staff Director on health to the late Senator Edward Kennedy. And then thirdly, Len Nichols is a non-resident fellow at the Health Policy Center at the Urban Institute. There he heads the Urban Institute's CAPCHI project, which explores innovative community-wide techniques to encourage investment in social determinants of health. Len has more than 2 decades of experience in advising government at all levels, and was and also the private sector in the healthcare area after being senior advisor for health policy at the Office of Management and Budget during the Clinton administration. Well, I see that Kavita has still not found a safe space to be in touch with us yet, but as I said, hopefully she'll be able to join soon. So let's start with you, Melissa, if I may. You've been tracking social determinants of health legislation and government action here and around the country for some time. What do you see happening in the near future in this area?
Thanks, Stuart, for the great introduction and for providing some background and context with respect to social determinants. I'm excited to be here today, and I'm looking forward to hearing from my fellow panelists, including Kavita, when she's able to join. If not, I will refer all of the hard questions directly to Len over here. Stuart asked me to speak a little bit about how Congress has approached social determinants and what they may accomplish over the course of the next Congress, which of course begins in January. And I'll talk a little bit as well about my thoughts about the next administration, but I know Kavita has been tracking this very intently, and so hopefully she'll be able to join and provide her thoughts. So first, I guess looking back over the last Congress or the past 2 years, there has been a lot of interest in social determinants and health disparities. Members have introduced a number of bills related to both social determinants, health disparities, health equity, and so on. Committees have released requests for information and formed task forces to better understand these issues. And this activity, I would say, is definitely expected to continue into the next Congress. So as an example of some of the legislation that's been introduced, I'll run through a couple of examples, including the Social Determinants Accelerator Act, which is a bipartisan bicameral bill introduced in 2019, which would provide $25 million in grants to state and local governments to help them to develop evidence-based cross-sector plans to address social determinants. The Improving Social Determinants of Health Act is a bicameral bill that would require the CDC to establish a program to improve health outcomes and reduce health inequities, and would award grants to eligible organizations across the country to build capacity to address social determinants. The Caring Act is another bipartisan bill introduced in 2019 that would require HHS to issue and disseminate guidance to states to help them to address social determinants across Medicare, Medicaid, and CHIP. And the Understand Act is another bipartisan bill which requires the collection and reporting of data on social determinants of health across Medicare, Medicaid, and CHIP. Additionally, there have been a number of bills introduced related to maternal health, including the Black Maternal Health Omnibus, a package of 9 maternal health bills introduced by Vice President-elect Harris, which includes the Social Determinants for Moms Act, and a number of COVID-related bills, which largely focus on data collection and efforts to reduce health disparities, which have come to the forefront during the course of the COVID-19 pandemic, including the Ending Health Disparities During COVID-19 Act, a large package of social determinants bills, which also include both the social determinants Accelerator Act and the Improving Social Determinants of Health Act. I should note there have also been many bills introduced to advance health equity that would expand coverage, access, and services, and would create new CMMI models, or that would increase funding for social services and housing and other types of efforts and programs to address social needs. So looking forward into the next Congress, reflecting on the results of the election that occurred 2 weeks ago, as it stands, it seems that the makeup of Congress next year is likely to be somewhat similar to the status quo. Republicans have gained several seats in the House, giving Democrats a slightly narrow margin that they've had over the past 2 years. And while there are 2 runoff elections occurring next month in Georgia, it is likely that Republicans will retain Senate control. Therefore, there will continue to be a divided Congress, bringing a slightly narrow pathway for social determinants legislation amidst all legislation to succeed moving forward. So although there has been a lot of positive momentum to date, in thinking about the bills that have the highest opportunity to succeed over the next couple of years, I think it is likely to be those that are a little bit more narrowly targeted and bipartisan, which to date have included bills focused on the need for better data, understanding of what types of disparities exist across the country, bills that would help identify and fund programs and demonstrations to determine, what works best to close gaps, and how to best scale or replicate some of the evidence-based programs that are being implemented across the country. And notably, most of the bills that I mentioned earlier in my remarks have strong bipartisan support and are poised to hopefully move forward over the coming year. So to touch quickly on COVID, as the COVID pandemic continues to grow and expand across the country, both Congress and the incoming administration will be laser focused on efforts to ensure states and providers are able to successfully distribute and administer vaccines, to ensure adequate treatment and testing, and to manage the economic fallout from what is likely to be a very difficult next few months. However, it's important that we emphasize and recognize that COVID has hit communities of color, older, and other vulnerable populations particularly hard, with disproportionate rates of infections and deaths, which are due in part to underlying social factors that many face. Therefore, both Congress, the administration, and states, I think, will need to take steps not only to ensure equitable distribution of vaccines and adequate outreach and education, but also other supports and services to vulnerable communities to help keep them safe and healthy as we continue to fight this pandemic. And then finally, just a quick note in thinking about the incoming Biden administration, it has, among other priorities that it's committed to addressing health disparities, including through increased data collection to better understand the scope of health disparities, additional funding for home and community services, steps to improve maternal health outcomes, and expanded funding to address homelessness and affordable housing, transportation, living wages, and other policies that would better address social needs and improve well-being. The Biden-Harris administration is likely to play a key role, in addition, in elevating the discussion around the importance of better identifying and addressing social needs, and in pushing Congress to advance accompanying legislation. The administration, I'm sure as Kavita will also speak to, will also have many levers to address social determinants through its own healthcare programs like Medicare and Medicaid, through the CDC, and as well through other federal programs across HUD, the Department of Education, Department of Labor, and so on. And it's also likely to expand upon some of the existing or develop new models through CMMI, existing models such as the Accountable Health Communities model. So in all, I believe there is a bipartisan path forward for legislation to address social needs over the coming years. And I do believe that the Biden-Harris administration will take significant steps forward to address social determinants through its administrative vehicles. So I'll turn it over to, I guess, back to you, Stuart.
Thank you. And actually, before I go to Len, would you sort of give a sense of just what proportion of the bills in the Congress are really bipartisan or backbench bills that are kind of moving forward in that way? And how many kind of really involve, or you think the leadership is going to be really crucial in moving something forward?
No, it's a great question. I think my answer depends. So there are, a subset of bills that are bipartisan, largely some of the ones that I mentioned. But those bills tend to be a little bit more, I guess, administrative in nature. So grant programs that would help to provide planning grants or pilot opportunities for demonstrations, et cetera. Some of the other major social determinants legislation that has been introduced that would focus more directly on addressing social needs, such as through increasing funding for certain social services, or expanding coverage or access to care. Those types of bills tend to be a little bit more partisan, and likely potentially will have a bit of a more difficult pathway kind of moving forward.
Yeah, I think we may come back and talk about some of those in a bit more detail later on. And let me just again remind everybody that to use the chat function, the Q&A function rather, to ask any questions as we go along. Let me turn to you now, Len. As I said, you've been looking at social determinants of health around the country for some time. A lot of things going on. What's your take on what's likely to happen even without some federal legislation or federal involvement?
Well, Stuart, that's the good news, given what Melissa just gave us in that masterful overview of what's possible and what's likely and what's not so likely. All the federal government really has to do is let states and localities do what they already want to do and sort of have permission. It'd be nice to grant a little more permission. Specifically, I will suggest that the Trump administration has done at least one good thing. They have granted more permission to do things through regulation for Medicare Advantage plans and special needs plans, as well as some Medicaid waivers, which I'll go into. But the truly exciting work in this area of late, I believe, has happened at the state and local level. And you got to start, I think, with that 1115 waiver that CMS approved that North Carolina got. And North Carolina is exemplary for a couple of reasons. Even though they've had some delays, which are due to partisan bickering. They do have a Democratic governor and Republican House, and they are now moving forward to implement what they call the sort of healthy opportunity pilots. And the fundamental idea there is to coordinate, essentially create the ecosystem of the social service sector and the healthcare sector. And uniquely in our nation, North Carolina used some of the 1115 money, and they got some foundation support to build a closed loop referral system, which connects all the social service providers and the healthcare system, which enables us to not only make referrals far more efficient, warm virtual handoffs and all that, but perhaps most importantly, track outcomes in a profound way, which enables us to demonstrate ROI and so forth going forward. So North Carolina is definitely a place to look. You could look at California's whole person care, Washington State's accountable communities for health. There's a lot of interesting things going on under the rubric of 1115s. And then of course, the delivery system and reform improvement plan, the DSRIP subset of 1115, New York, Texas, believe it or not, Texas didn't expand Medicaid, but they had 40 something, I think 44 different DSRIP initiatives. So they too took advantage of a lot of ways to reach upstream and grant these freedoms. Now, in general, what Medicaid agencies have tended to do so far is not be prescriptive, but rather permissive. Say, we encourage you to do this stuff and look upstream and start paying attention. There are a couple of pathways, of course, that are relatively well known about how money spent by managed care organizations with a Medicaid contract can count in their MLR, or at least can count to set rates next year and so forth. But by and large, most of the activity that states have done so far is less RFP prescriptive and more permissive. And that's sort of good because everybody kind of had to walk before they ran. But there is, and I think it's important to keep in mind, particularly for the discussion today, there's a natural tension between, on the one hand, folks who want to use existing healthcare money to spend upstream. There's a tension between that and a natural philosophical, indeed, maybe even practical reason to limit how much Medicaid money could and should go to social services. A one-liner I like to use when talking to folks is there are not enough healthcare savings to pay for utopia, right? We cannot save enough out of healthcare in order to pay for what we need. And that means the flip side of that is there's not enough care coordination. That's not enough. We need more. We need more spending in total to improve the equity of our nation and certainly to solve these larger upstream problems. But there is enough money in healthcare and there is enough focused interest in healthcare organizations that we can do a lot of good if we just allow these local initiatives to flourish. And so let me move now to the local area, which, as you know, Stuart, is where I've been focused most of my time. And I would just observe a couple of things which everybody knows. Local leaders actually do know best about what their community needs. I mean, you could do a survey of any place in the United States and the top 5 social determinant needs are the same, but the rank orders differ. And in particular, what may differ is what is the item that is causing the most pain right now, you know, and it could be behavioral health, it could be housing, it could be food. So there are lots of different ways to order the priorities. And that's why I believe you want the local folks to be the leaders in this stuff. And so I've started this little project called CAPG, which folks can get a link to. But fundamentally, what's going on there is we've observed communities that want to solve an upstream problem together, and they need a mechanism to enable them to do so around the so-called wrong pocket problem, which you've written eloquently about, but also what I call the public good problem or free rider problem. That is, people can't get a return on their investment because the investment upstream will benefit multiple organizations downstream. And so we've got a model and a process that seems to be appealing to people. And Cleveland is actually implementing it for medically tailored meals for socially isolated seniors starting in January. We've got other communities like Spokane, Washington, and now Anne Arundel that are focused on housing. Grand Junction, Colorado is focused on supportive services for socially isolated seniors. Waco is focused on diverting folks from ED and jail to get to a proper behavioral health as soon as possible. Kansas City's focused on reducing readmissions. And what's cool about all these initiatives, they come from different sort of vantage points. They have different leaders on the ground, and yet they have a common purpose. And that common purpose is to work together to solve a problem that they share. And that indeed, what they need the federal government to do is basically just grant permission to do what they know they want to do. So when I look to the future, and I see an incoming Biden-Harris administration, I totally agree with Melissa. I expect them to be not just sympathetic, but proactive in this space, because everything we're talking about is solving the issues they have highlighted in the campaign around equity. I would suggest that COVID and the Black Lives Matter protests have demonstrated in a much more profound way than perhaps we had as a country before the cost of inequity and the avoided reckoning with the racial unfairness we've had in our country for so long. And I think we're going to see that addressed, if not through Congress initially, certainly through regulation. What I hope to see, and I'll be glad to see if Kavita backs this up, but I think you're going to see the federal government try really hard to look across sectors to try to get housing and healthcare and transportation and labor all to work together to start looking upstream. And you can do a lot of that with regulation without, or just in fact, interagency cooperation, and does not need new legislation. Finally, let me just say the good news out there, Stuart, is a whole lot of effort being devoted to data. Melissa mentioned a number of congressional bills that are focused on acquiring data and so forth, and hopefully collecting and moving that forward. But already, these closed loop referral systems like Unite Us and Aunt Bertha and Healthify, they're enabling the healthcare sector and the social service sector to integrate their coordination of services for people in a much more profound way than ever before. And I think it's fair to say that coverage expansion had the effect of putting the homeless, for example, on healthcare plan roles, which has led to a deeper awareness on the part of the health insurance world of what the upstream needs really are. And I think there's nothing that's more catalytic for the future than that awareness being spread over time. So let me stop. And
all right, thank you, Len. And before we go to questions from the audience or some of the questions there, let me just have a quick follow-up about the Medicaid waivers that you mentioned, the Section 1115 waivers. Of course, those, as you pointed out, are permissive. It's the federal government agreeing to allow a state to do something. And of course, it does tend to reflect the vision of the administration in power as to what they want to encourage to happen. Do you see any significant changes in that pattern? Are there things that happened under the Trump administration that you think either will be less inclined to happen under Biden or vice versa?
Well, Stuart, I think it's fair to say that the Biden-Harris administration is less likely to look favorably on work requirement elements of waivers that have been attached in recent years. But I think they're likely to look as favorably, if not more so, on the kinds of initiatives like North Carolina and California and Washington have pursued, precisely because those kinds of broader utilizations of the Medicaid authority and Medicaid money to reach deeper upstream are consistent with the Biden-Harris administration's goals of achieving true equity over time. So I think there'll be more North Carolinas and fewer Indianas, if you will.
Interesting. Would you agree with that, Melissa?
Absolutely. No, I do think that one of the Biden administration's kind of primary objectives coming in is likely to be, reevaluating some of the guidance that they've released with respect to work requirements or their kind of block grant proposal that was released by the Trump administration, and rather kind of rescinding that guidance and instead kind of pushing new types of guidance and opportunities for states that really do, as Lynn mentioned, kind of expand upon what North Carolina has done and what other states have done, including California with their whole person care pilots. Initiatives like that, I imagine they are definitely going to be promoting and trying to encourage states to expand upon.
Okay, good. Let's move to some of the questions from the audience. And then let me just encourage everybody who's watching to take the opportunity to ask a question that we can send on to the panelists. First, Rich Daly has asked, what specific steps could the Biden administration take on social determinants of health without Congress? In other words, kind of what specifically policy examples as opposed to generalities? What specifically do you think you're going to see happening? Maybe Melissa, both of you can probably take a crack at that.
Sure, I'm happy to go first. One thing that I have definitely heard a lot about from, let's say, health plans is, an issue and clarity with respect to, let's say, financing for social needs. So one thing that we have heard a lot is, interest in gaining more clarity from CMS with respect to, to the extent that they might be paying for care coordination, social services, whatever it might be, ensuring that that is allowable in the numerator of the MLR, for example, or gaining additional guidance from CMS as far as, expanding upon existing guidance that CMS has already put out as far as, what types of, I'll use Medicare terms, like primarily health-related services are allowable under using kind of Medicaid dollars rather than plan dollars through their in lieu of or others. So I think those types of things through CMS is definitely an easy or kind of low-hanging fruit, so to speak, that the administration might want to do. And I know that they have been thinking about this and talking about this for several months, if not years, having internal conversations about, different ways that they can better promote some of this work that is, starting to emerge and bubble up across the country.
Yeah, I would definitely agree with everything Melissa just said and say I expect them to both expand the kinds of freedom that have been granted lately and clarify in more precise red line terms what's there. And Stuart, I would also suggest that a lot of what can be done without legislation could be to compel the agencies to cooperate. As you know, as we've all learned from Kathy Stack over the years, I mean, there's a heck of a lot of sort of ambiguity in instructions from individual agencies to the local implementers, be it county government or state government, and that ambiguity, or I'll just say distance from the black line of what's permissible, has kept people paralyzed. And there's a lot of guidance that could be issued, in my opinion, and other people's who know more than I do opinion, if the agencies were, if you will, encouraged, if not forced to cooperate, that would clarify precisely where those lines could be drawn and where indeed creativity which again, the people on the ground know what they want to do. They just need the freedom to do it. And I think in particular, if the Congress remains divided, I think it's likely that you'll see this administration explore exactly how far you can push that kind of guidance. And that clarification of that guidance across agencies could have a profound effect on the creativity on the ground. And again, spend existing dollars, not new dollars, but in a way that's more effective.
I see Kavita has joined us after a little bit of excitement.
I did. I got nothing like a real fire drill.
A real world situation. But
to get you, we literally were. I was literally dialing on, and I was waiting. So I apologize, Stuart, because I thought it was fake fire drill. It was a real fire, but not real fire, but real fire drill.
All right. Well, I'll come back to you in just a second. But I just want to follow up quickly because Rich Daly's asked actually a follow-up question, which may very much apply to what you said earlier, Len, asking, do you think the Biden administration will rescind waivers issued by the Trump administration? In other words, what might it block some of the things that are part of this whole conversation about social determinants?
Well, I don't actually know if they have the power to pull it back en masse. But I think interpretations of satisfying guidelines might be a little tighter around some of the work requirement kind of stuff. But I would, let's put the work requirement stuff over here and the block grant stuff over here as sort of ideological. Most of what the administration has approved in this area, both in Medicaid and Medicare, is welcome. And I just expect Biden to continue it. So I think if it's more of a shift in emphasis away from those ideological things and an expansion of permission and clarity in the areas where we all want to go.
Okay, great. Well, Kavita, unfortunately, you've missed a little bit of the dialogue so far, but I don't think it would surprise you. And maybe I can just ask you, as somebody who, as we saw today, sees social determinants of health up close and personal as a physician. And you've also seen how administrations can move things forward or not move things forward. So I wonder if you just take a couple of minutes to just give you a general sense of how you think the administration, the new administration, is likely to give some energy to social determinants of health, either administratively or on the Hill.
Yeah, I think that there's no question that social determinants will be a prominent aspect of all policies, kind of like I think Len and probably Melissa would agree, and probably mentioned also the emphasis on, race, equity, kind of thinking through these issues, even in just trying to come up with their policies. I'll say a couple of things. Number one, we have had opportunities in CMMI to really expand some of the accountable healthcare communities, even though that model was one of the ones that had been determined to not necessarily be as robust as potentially some of the other ones. I think that everybody has taken from the example of accountable healthcare communities the concept that more explicitly measuring social determinants of health or finding a way to incorporate that into claims data is valuable. I think payers are asking for it. And then maybe interestingly enough, Stuart, I think that there's been now enough attention by the commercial insurers. They're all kind of this, United has an insurance arm for Medicare, Medicaid, and the commercial arm, but the employers are kind of talking about this. So I think a Biden administration is going to work to kind of pull all levers. I think, anytime you have that opportunity, you try to do it in multiple different settings. Medicaid, I'm in an FQHC where everything starts and stops with social determinants. But we have such uneven policies from state to state. In Maryland, I can get my heating paid for, and in the district, I can't. Maryland, I can get vaccines paid for with a face-to-face visit. In the district, I don't need one. I think that ability to look, I am looking towards a new Medicaid director at CMS to be a little bit more sophisticated. And your concept that you've written about blending and braiding kind of budgets, I think will actually have more legs given the waiver authorities, which I hope the ACA stands and continues. But then also two, what I would say has been this decade of experimentation. We've had this decade to think about duals programs, the good and the bad, CMMI, 1,000 flowers blooming, good and bad. And so look for the next decade, starting with a Biden administration, to define this a bit better and how to promote the like ideas around social determinants. I think there's still going to be some tricky issues, however, not to, so that sounds really optimistic, which I am, but then I do think there's going to be some hard budgetary realities that one of the most important social determinants is employment and housing. And it's hard to pay for, I mean, if I could do housing vouchers based on the data we have from New York and people who have done it, I would, but it's expensive and we can't, you know, Obama didn't do it. Anyway, maybe that's worth talking about later, Stuart, but that's just a little bit of a reality check on some of these things. It's all good and fine when it's Lyft vouchers to and from the clinic. But when we're talking about, you know, incredibly kind of either higher stakes, more dollars, it becomes harder.
Thank you. Yeah. Yes, I think the data issue is definitely one, and Len referred to it earlier in terms of some of the things going on at the local level. We also know, of course, that unfortunately our ability to demonstrate the effectiveness of focusing on social determinants is probably less than we would like in terms of what research has been done and so on. So I think there's clearly a need for a lot more research in this area. There's a question from Kathleen Noonan saying, I've heard some chatter of a high tech for public health or social services. What have you heard about that, if anything? So anyone want to take a crack at that in terms of what other things are happening in the development of data?
Well, I've heard no chatter of high tech, and I defer to Melissa for any known bill cited or unseen at this point. But there has been a lot of discussion of what to do about the lack of data infrastructure in these communities that have not yet benefited from. And let me just say, those closed referral systems I mentioned, Unite Us, Aunt Bertha, Healthify, et cetera, they have this great potential, but they're not perfect either. And as in all things American, we tend to think, oh, here's a new technological solution that'll solve everybody's problem in 48 seconds. And if those of you who've ever tried to make Outlook change, you know exactly how hard this is. So what's going on is people, again, are aware of the value of the data structure that can enable the ecosystem of health and social services to cooperate much better. People are still trying to figure out what's the best way to organize that. And at the time, we have sort of, I would say, wild, wild west. You've got health plans looking for partners upstream. You've got some of those systems I just mentioned, sort of creating networks of CBOs, the community benefit organizations that provide the services to the people. You've got hospitals doing all of the above. And meanwhile, the community benefit organizations, the ones that are really the people doing the delivery, they don't have IT departments anywhere near like the hospitals or the health plans or these closed referral systems. And so they're being inundated, and indeed, in some parts of our country, they're actually pushing back and saying, wait, we got to reorganize this. So I think you're going to see some of that kind of sifting out in the next few months and years. And I think the Biden administration will try to get in front of it. I must admit, and Kavita may not agree with this, but I sort of shudder when people say, let's do high tech for social services. I'm not sure if that's the way, but what we do want to do, I think, is pay particular attention, go back to my theme for today, of what the local voices need and want, because they know better. And in some places, I'll just say, you might have a great ecosystem that is completely functional without any federal intervention because they happen to have a homegrown information system like Grand Junction, Colorado, where they have a world-class health information exchange. They've got trust of all the local players. Leave them alone, okay? But other parts of the country, you probably need some standards and probably maybe even some managed competition, if you will, to enable this stuff to work, to protect the CBOs, to enable the social service sector to serve the healthcare sector and work together to serve the clients involved. If you don't do that, then we're going to end up spending too much and not getting enough output.
I see a sort of a comment question by Kathleen, as a follow-up here, saying that closed referral systems generally do not bolster local public health or social service organizations. She says, and we know, as we have been running an Aunt Bertha white label since 2015, that we need more investment in the data area. But let me switch to back to an earlier question from Andy Biasi, also about waivers. I mean, we mentioned what waivers might or might not be continued, or what new ones might come in. But she asks, could some of the waivers where we have some experience actually lead to permanent changes under a new administration? In other words, this is something that the Biden administration might conclude from existing efforts on the ground that have been made possible by the federal government to actually push for changes in the law. Anybody like to try to respond to that? Maybe Kavita, I mean, as you mentioned, there's lots of differences across states in what's covered and not covered, and so on. Might that be an area?
It could, but I just feel, I guess I'm putting my old Senate hat on. It just becomes like, it feels easier for me to think about a program, like states are all hurting, doesn't matter what state you're from, states are all hurting. And it feels easier to think about doing that and threading the needle through programs which offer, frankly, kind of financial incentives to the states to try to figure out some way to align, to undo in potential the states where you've had either onerous work requirements or things that are impeding access. But I don't know how to map that. Like, I think that becomes harder to think about mapping it to legislation. I guess my concern is that it's hard to, legislation becomes this kind of blunt policy that you use to try to generate savings or to try to gain some sort of like traction on an issue. This doesn't rise to that level in my, but I could be wrong. I'm not trying to say that it's not important. It just feels like this very divided Congress has even more hurdles, and I would be more excited about figuring out a regulatory path rather than legislative, if I understood you correctly, Stuart.
Yeah, I mean, I think the question is, we've learned a good deal from some of these waivers. Are we likely to see that become a new part of the law?
Right.
Clearly saying that's less likely.
If I could, I would just observe that, one opportunity, in my view, for bipartisan support for this sort of thing is if you think about using regulation. Typically, Republicans oppose Democrats using regulation because they look at it as restricting. But the kinds of regulation we're talking about in the social determinant area is actually freeing states to do more different things. And I think you're going to find more Republican support for that application, particularly since it really just follows in the same direction that the Trump administration already started with North Carolina, et cetera. So I think, in fact, you could get a long way to where you want to go just by having CMS reinterpret those words that I think, whether Melissa or Kavita said them, medically necessary, in lieu of, all those things are vague enough. You can drive a whole bunch of social determinants through them if you just make the guideline clear enough. And that's what I expect to see.
Can I say, though, I think that's where, I know we've got a bunch of policy luminaries in the audience. So I think this is where I think a lot of people are making some assumptions that, like, okay, the Biden team's got a lot of Clinton and Obama alums. They're the smartest in their game. True. But I think this could be a valuable place for Stuart, places like Brookings and others, Urban and other RWJ, all of us to weigh in with some almost very clear tactical ways to do this. Because I hate to say it, like when I was sitting on the front end of an administration or Congress after we got majority, minority, I didn't have like a bunch of this. I didn't have specs I could go to Ledge Council with. I also didn't have things I could turnkey into easy letters to the directors. I think they're going to need stuff like that. Like with everybody on pandemic fire 101, anything we can do that can be turned quickly into a dear Medicaid director's letter, anything that we can do that can be turned into ledge language, I think would be huge.
Right. Just on, of course, many people say that one of the great things about pursuing social determinants is that taken together, it improves the value of the healthcare system in terms of what it can do. And Michael McKnight asks, where do you see payment models such as value-based going in the future, and how that might affect this? They were promoted, he says, by both, value-based payments are promoted both by the Obama administration and Trump administration. Are we likely to see value-based payments being one of the engines to drive social determinants more? That's my editorial at the end.
So I can start. I would say
Sure.
yes. And I'm sure the others will have lots to add on. But I do think that one of the things that has driven the healthcare sector's interest greatly in social determinants is this kind of expanded use of value-based care, where entities are being held more accountable for outcomes, for healthcare outcomes. Largely, a lot of that is driven by things that occur outside of the doctor's office, right? So to the extent that value-based care is going to proliferate, that will in theory also drive more interest and expansion into interventions that are aimed at better identifying and addressing kind of social needs across the board. And to the note about expanded use of value-based care, I think there's a lot of interest in a bipartisan nature about expanding value-based care and kind of moving away from fee-for-service models. I think the challenge is trying to make sure that the incentives are in place for various providers and plans and others to really take this up and run with it, especially when they start to encounter models that might incur downside risks. And so trying to make sure that providers, especially in a COVID context, feel like there is value for them and incentive enough for them to invest in this and have the ability to really track all the claims, really understand what is going on underneath the hood in their patients' lives, I think is going to be a challenge. And something that I think the next administration is definitely going to have to think about as they move to kind of build upon the foundation of value-based approach that exists today.
Okay. Michela Duran asks a question that drills down a little bit further on this whole issue of data and waivers. Hang on just one second. And says, part of Indiana's waiver focuses on improving social determinants of health data reporting from Medicaid beneficiaries. They can now drill down by county and discovered that food insecurity was a major issue. When you say that there will be less of Indiana and more of North Carolina, I think this is aimed clearly at Len, does your statement include this type of work that more conservative states have generally advanced in expanding Medicaid under the political cover of work requirements?
Great question, touche. I was speaking to the work requirement element of Indiana, and that's what I think you'll see less welcome in a Biden-Harris administration. But I've never met a Democrat who didn't love data. So I think it's highly likely that they'll, in fact, the collection that was started arguably with CMMI's Accountable Communities for Health is spreading across the country. So absolutely.
And certain states across the country are also starting to require through like managed care contracts that plans are screening individuals for social needs. Like Len, I'm sure you're aware, North Carolina is one of those states and actually has built in as part of their managed care contract kind of a quality performance measure to ensure that their plans, once in fact they are in place, are collecting data on social needs. Rhode Island is doing the same, Massachusetts is doing the same. So it's intent, to your point about interest in better understanding what these social needs are and having the data to better direct some of the efforts. It's making sure that there are incentives in place, requirements in place, that the data is actually being collected and therefore can be used to drive outcomes.
Dr. Seiji Hayashi goes back to the point you made earlier, Len, and others did too, about the wrong pocket problem, the mixing of money, and the challenges of getting departments to kind of blend and braid money together to go down the route of social determinants. And he says, because of the wrong pocket issues, and even within the Obama administration, he says CMS refused to pay for housing and other social determinants of health. Would a Biden administration be willing to push the envelope further towards blending and braiding in this way? And I think that gets back to this pretty fundamental point about whether Medicaid money and maybe other strictly health money should be more open to that being used for non-clinical services like housing. And I know there's a lot of disagreement about that. So wonder if anybody would like to respond, whether he thinks, whether you think the Biden administration will move us more towards using that money in a more flexible way.
So I think the North Carolina waiver is possibly instructive here. If you look carefully, what it says is they can pay for up to 6 months of rent upon discharge from a hospital if the person would have to go otherwise homeless. And that is, in a fundamental sense, at least they believe it to be, both North Carolina and CMS at the time, justifiable in terms of the impact on the person's health. Okay, but there is clearly a line somewhere between discharge and post-discharge life where it becomes less impactful on someone's health. So I don't actually expect a tremendous amount more movement in allowing Medicaid dollars to be spent on housing. What I do expect, Stuart, is more freedom like that around the edges, if you will, or around discharge and so forth, and supportive services. But what I do expect from a Biden-Harris administration is more coordination between Medicaid and HUD, more coordination between the agencies writ large, so that existing appropriated dollars can be directed in a way that's both good for the patient client and arguably more cost effective for the missions of both agencies. And that's what I expect to see, this guidance we were talking about earlier, and perhaps some legislation if we get smart later on.
Melissa Kavita, do you have any additional comments on that? If not, that's fine. Let me
Agree
move.
with Len.
On me?
I said I agree with Len.
Okay, that's good. There's a question from Erica Brown, which is more broader about the role of the federal government, I think, in encouraging social determinants. She asks, do you have any specific ideas about how the federal government can help build both the interest and capacity needed at the state and local level to advance social determinants of health? Maybe a new Medicaid waiver program, or the CAPG, encouraging the CAPG program that Len's involved with. What kind of things can they do? I mean, I've written about even things like giving clearer guidance to states about what they can currently do, which is often a big problem, or looking at the HIPAA rules in terms of how information moves around. Do you have some sort of favorite proposals or ideas that you would like to see the new administration pick up? No great thoughts.
So I can share.
Asking policy people to think of like new ideas. That's correct. I'm just teasing.
Yeah.
There's so many areas to go into. Sorry, Melissa, you go, and I'll come up with one at least.
No, I was just going to reflect.
Handsomely for at least one.
I was just going to reflect on the fact that, you know, that I think is the core of the issue, in that, you know, state and local governments and other entities across the country, you know, this, you know, better or worse, and especially in a COVID environment, this type of, you know, really difficult, you know, navigational work to kind of think big and try to figure out cross-sector evidence-based solutions is not easy. And it often does take, you know, dedicated time, dedicated resources, dedicated staff to kind of pull all of this together. And that's why, you know, things like what Len is organizing through his CAPG model is so instrumental, because it does provide like dedicated time and resources and expertise to come in and help kind of drive and catalyze some of this activity at the state and local level. But, you know, to the extent that a, you know, incoming Biden administration can help to drive some of this, I mean, I think there's always opportunities, perhaps through demonstrations like through CMMI or other challenge grant opportunities that, you know, provide, you know, a little bit of funding that, you know, can perhaps fund a dedicated staff person that, you know, their whole job is not necessarily the day-to-day operations of a given agency, but rather in really thinking through some of these, you know, cross-cutting difficult issues. Or, you know, as we through Aligning for Health have been, you know, trying to advance, is thinking about ways that Congress can also dedicate, you know, specific funding to HHS to then provide to state and local governments so that they have, you know, additional capability through that as well.
Right. Yeah, I think we all agreed that the federal government has a range of tools, everything from information to guidance to waivers and so on, to make a lot of things happen. There are a couple of questions, a two-part question, I suppose, from Pablo Bravo at Dignity Health in the West. He says, first of all, do you think the introduction, and this is first of all on the data issue, do you think the introduction of Unite Us, which Len mentioned and Aunt Bertha, will actually burden organizational resources at the local level? And do you see the role, how do you see the role of community empowerment in making permanent changes, really to build in social determinants on a regular basis under this new administration?
Well, I think I mentioned that there have been instances, some of which from the West, which your inquisitor probably knows, where the CBOs felt like they were not being listened to, and they felt like they were having to sign up and plug into and figure out how to master 7 different portals. And so unmitigated competition among the closed loop referral systems in a given area, in my opinion, can be burdensome for the CBOs. At the same time, I think it's fair to say, I mean, I'm an economist, I believe, in competition. I think what they should do is have local areas compete for the right to be the closed loop referral system, let it be a temporary monopoly, and let other people compete. Let's Unite Us win here, and Aunt Bertha wins there, and Healthify wins over here, and everybody's busy because there's plenty of work to go around. But then within a given area, the people driving the specifications for that competition and the requirements on behalf of the CBO network, those folks are local. So they become, in essence, the buyer. Now, in the short run, they may not have the money to buy, and that's where some kind of federal injection might be helpful. But I will tell you, health plans and hospitals are deeply invested in making these choices as well. And so their money may also be quite tappable, if you will, to make this happen. But I think the question is absolutely correct, that there's got to be local control to prevent it becoming a burden, but it does not have to be a burden. It just depends on how we learn to manage it.
Mm-hmm. I see a question from Daniel Davis, who's with the Administration for Community Living at HHS. And he's asking a question about disability data. He says, disability data and measures are far behind data for other populations, but people with disabilities are clearly facing a number of disparities in various aspects of social determinants of health. Data collection is quite expensive, but the need for such data to support interventions is clearly needed. Do you have any thoughts regarding how to ensure adequate investments in data and measures for such underserved populations? Any thoughts on that?
I'll add, I was part of an effort trying to look at how we could collect this data. Now it was when I worked for Kennedy. I mean, it's been a long time coming that we've acknowledged a lot of this. What we understand, here's what, let me turn it into something prospective. I think that the investment in data and measures, and whether it's populations related to disabled adults and children, or even, we couldn't even find caregiver information on people who were kind of institutionalized or have like mental competency issues. Like, that's how bad it is. So I think that this is where, to get back to that high tech question, which I also cringe when you say high tech, I do think that the next phase, if we can get beyond like some of this interoperability, transparency, like tete-a-tete, that we do need to have a much more robust integration between like the Office of the National Coordinator of Health Information Technology and CMS and housing and labor. And I do think that like the Biden people get it. I think doing it is going to take some time. So I would love to see requirements. I can find a way to do some of this in my own EMR, but they make it really hard for me. So I would love to see something where those of us who are taking care of people inside nursing homes and inside clinics can report this data. CMS needs an extractable file so that they can kind of put that into claims. And then we need a way to have that be publicly shared so that we can understand and gain insights from it. And Medicaid data architecture is, if you think Medicare data is limited, Medicaid makes Medicare look like, it's a billionaire and flush. Right. And so we need to start someplace. And I'm okay with starting maybe in some of these limited settings under a pilot or something, but we need to start to kind of also push onto the IT systems an expectation that this is part of what is just reporting to some degree.
Yeah, and I think you'd agree that building up the data, the ability of organizations to collect the data, to process the data so it can be reported is often very limited. And there are organizations like Project Evident that are working with organizations at the grassroots level to build those data systems and so on. And then I think, as you said, just making sure that across agencies, really at all levels of the federal system, that this kind of information is shared and processed and so on. We have cabinet, as I said, children's cabinets at the state level that tend to do that. We do have at the federal level, of course, the U.S. What's it called? The Council on Homelessness that explicitly coordinates across the federal government and with states and localities. And maybe this is an argument for something similar in this area, how we can achieve greater equity and use of social determinants by setting up some kind of council of that nature. Let me move to a question from Ann Ricklin, who is at Fairfax County, part of the Fairfax County government system. And this is to Len. It says, Len, you mentioned an example of a place, of an operation connecting healthcare and housing. Can you say a little bit more about that model? I think she's referring to the CAPG model. Or maybe something else that you said.
There are a lot of people out there who have pursued Housing First. And Housing First, of course, is the program that's been around for 20 years or so, I guess. And the fundamental idea is, instead of requiring individuals to achieve a certain level of sobriety or whatever, put them in a house first, put them in an apartment first. And then it turns out you reduce the chaos around them sufficiently, they're much more open to the kind of social service, social work, care, case management, et cetera, that enables them then to free themselves of addictions and maybe go on and work and join productive society. And so Housing First has been tested in lots of different ways. There have been 2 huge sets of randomized trials in North America, one in Canada, one in the United States. And it's been shown fairly frequently, I'd say often enough, to actually save enough money to pay for the housing for specific subpopulations. And those specific subpopulations are folks with serious mental illness and or substance use disorder, plus typically a chronic condition or 2. And so they are the high cost, high need. And that kind of focusing on the high cost, high need homeless has attracted a number of interventions around the country. United Healthcare has done some. The Spokane example, using eventually will be using our model, is another one. And Cleveland is doing it without our model in housing. They've been doing it for a long time. Cleveland, in fact, is about to reach functional zero for chronically homeless. They've been doing, and so there's a lot of different ways to do it. But as I think it was Kavita was saying, paying for the housing is a non-trivial problem. Okay, and so building new buildings is in fact quite expensive. Now it turns out, and I'll just say in the Cleveland case and maybe in other cases, there are these tax credits that builders get for building high-end buildings that can be used. Then that, if you will, trading of tax credits has enabled some communities like Cleveland to achieve an amazing degree of success. That is not available in every place in the United States. And so you're going to have specific housing money. But in general, I would say there's been almost a consensus now that if you really want to improve the health of the homeless, you're going to have to provide some kind of housing for them. And since now, again, the homeless are on the rolls of health plans, suddenly there's a lot more interest in that. And I think, therefore, we'll continue to see creativity around that solution.
Can I, Stuart, can I just cite, because Pablo is on here, and I'll put it in the chat link. I used to be on the board of Dignity Health, and they have a partnership in Sacramento where they do provide housing. It's a special 18-bed unit, if I recall, kind of like near downtown Sacramento, and they length of stay for homeless members are it's about 20 days. And then they followed, they got data to look at kind of where people are coming from, and also to look at its effect on readmission rates, which were decreased obviously, and also like ED visits and so many factors. So I'll put the link And Pablo Bravo, who I'm outing, who's a very busy man, but helped to really champion and lead those efforts. But I think he would even tell you, like, it's all kind of hand stitched and band-aided together. It's not necessarily, even despite that incredible evidence that I would argue pays for itself, to Len's point, you know, it's not, and especially coming out of COVID, I hate to sound like this and be a downer, almost every health system I'm talking to is in billion-dollar red deficits because of COVID and kind of the delay or changes in elective surgeries and other procedures. So it gets harder to ask for those dollars if it's kind of after everything is done.
Yeah, I think it's a really interesting area, though, as I think we all agree, this housing health connection. There's a lot going on there in terms of exploring opportunities. The Council on Large Public Housing Authorities is very engaged in looking at how to connect public housing and health, for example. As we mentioned, there's a number of health plans that are sort of exploring ways in which they can work with people in housing and even construct housing, or at least finance it. In part, Bon Secours in Baltimore has been doing that for a long time. Other health systems as well. There were a lot of issues with that, as we know, that fair housing laws sometimes make it really difficult for any institution to say, we're going to really focus only on our members in this area, and so on. So there's a lot of issues like that, but it's certainly, I think, for everybody to know on this call, it's an incredibly kind of important growth area. And of course, the numbers have to be very large. Housing is not cheap, and it's a major investment, but it's a really important one. To Pam Brown, who's in Anne Arundel County in Maryland at the local management board there, asked about a broader question. What do you think we will see in terms of looking at this whole issue through an equity lens, and in terms of federal policy, sort of seeing this? I think several of us mentioned earlier that COVID-19 has shown very sharp differences between different groups, both income and race, type of job, and so on. Do you think that under a Biden administration, and again, I'm elaborating on the question, do you think a Biden administration is going to take more of this equity strategy and thinking about the importance of social determinants in dealing with health policy generally? Any of you like to take a crack at that one?
Go ahead, Melissa. You've been quiet for a while.
I mean, sure. Yes, I do think that they will take a very intentional approach to trying to advance health equity for all of their programs. They have, as so much as stated that through some of their, written materials as part of the Biden-Harris platform. And I think some of the folks that they'll likely bring in to staff some of their agencies, I think will be those who are well informed on these issues and will intentionally kind of take steps to infuse kind of the health equity lens across all of the different programs that they'll be responsible for and hoping to implement over the next couple of years.
It's very interesting how data issues keep coming up in the questions. This issue, it's not just money, but being able to know what's going on, to share information, to find out what the potential return on investment is, and so on. There's a number of questions here. Dr. Hayashi's come back with talking about health information exchanges and their potential role in this area. As he said, we're still not very good at exchanging information between social services and healthcare. And are there any ideas for improving that exchange of information? And Daniel Davis comes back also saying disability data and measures being very essential for social determinants of health, but data collection is quite expensive. Do any of you have any specific thoughts about how to ensure an adequate investment in data? We've talked about it being important, but do you think there's prospects at either the federal, state, or local level, or maybe even in part the nonprofit organizations, charitable organizations, to really sort of crack this nut and get real effective data collection and data sharing?
So there's a lot going on that I think, at least I didn't know about until fairly recently, so I'm not sure how widely it's been it's been promulgated, but you should Google open referral, which is a nonprofit initiative started by the guy who used to be the data geek for Bread in the City. If those in DC know what I'm talking about. So he knows whereof social service data speak, okay? And what open referral is about is exactly this question, Stuart, of how do you connect healthcare and social services in a way that standardizes the transfer, not only of the referral itself, but of the outcomes and you know, sort of what happened if you go to the food bank or whatever. And so fundamentally, yes, there's a lot of technical work. That open referral initiative is designed to get everybody to adopt a certain kind of standards, just like in EHRs. We finally got to the place where that was present. These closed loop referral systems are kind of pushing the question, because some, but not all, have adopted these standards, and there's a lot of pressure on them to do so. And those standards, I think, will go a long way toward enabling quality data to be exchanged. Now, the question about collecting, I don't know enough about the disability sector to speak anymore, so I'll shut up. I'll just observe that special needs plans are now, like some of the Medicaid MCOs are required to start reporting some of this activity. And I think I was going to ask Melissa if in some of those bills that are in Congress that are bipartisan support about data, are they focused on particular populations or anything like that?
I'm not. I'm sure that there are some that are focused on particular populations, but there are a number of pieces of legislation, especially in the context of COVID, that have been introduced that are really focused on ensuring that across the board, the federal government is incentivizing or requiring additional collection of data for purposes of better understanding health disparities. But I do agree that, you know, there's a couple different issues at play here. And one is kind of incentivizing, you know, the folks at the point of care or point of touch with a consumer to understand, or beneficiary or patient, to better understand what their social needs are, collecting that data, being able to input that data in a way that is then, you know, standardized and able to be ingested, whether it's by an EHR, whether it's by you know, the systems that a CBO or other social service agencies might be using, that it is, to your point about kind of the referral networks, that data is, you know, coded in a way that it's able to be standardized and shared across all of that. And then, you know, being able to then all the way, you know, I'll call it upstream, but then being collected by the federal government, so to speak, for the federal government and states, really to kind of better understand, okay, what is this data telling us? How do we, you know, better drive some of the interventions that we know need to get done, and perhaps focus some of our efforts based on what the data is showing us. One just kind of quick example of this is CMS in January of this year released a report on collection of social needs through Z codes, so diagnosis codes. And I think it was only like 1.4% of Medicare beneficiaries through their records were found to have social needs. I don't know the exact number or what the exact estimate of Medicare beneficiaries that likely have social needs, but I would guess it's much higher than 1.4%. And so I think there's, you know, that question of that gap that exists to date of, you know, better identifying the data, but then also or better identifying the social needs, and then all the steps that go in between that doctor-patient relationship, or that, you know, social service provider client relationship, to how do we then kind of take that all and ensure that we're all better understanding where those gaps lie.
Sarah Singleton, who's with the National Alliance to Impact the Social Determinants of Health, points out, just give me 1 second, it just slipped, asks, we're excited about the possibility of more government-wide efforts on social determinants of health. And she asks, which relevant executive branch departments do you think need the most education or resources to bring along this kind of thinking in the federal government? And maybe you might add, who do you think might take the lead in general within the federal government? Would it be HHS, or are there maybe others? But who needs most help in the federal government to really understand the opportunity here?
Do you want me to answer, Stuart?
Sure.
Yeah.
So I'll just, I've been a little nervous because like it's a typical maneuver of Democrats to set ourselves up to fail. So I feel like, let me just level set. Like, I think that as incredible as anybody coming in, and I'll just say it blatantly, like it's a welcome breath of fresh air that we'll have officials who actually like are probably talking to stakeholders, convening, et cetera. Having said that, like there's just so much in front of them that I worry a little bit like that we're expecting for everything to just be perfect from January 20th on. And so I want to give my brothers and sisters who are going to come into service a little like breathing room to say this will be top of mind, but it might take a little time just to kind of see the fruits of their labor. And to Sarah Singleton, by the way, an incredible Senate alum as well. She knows how this gets done. But I would say that the biggest issue here is that I think we talk a lot about social determinants of health. When you talk to anybody who's not on this Zoom, they're like, what? And so I think there's got to be like I would say the places that probably need the most help are kind of our other agencies outside of Health and Human Services. But I would also say that like we probably, and I've heard smarter people than me speak about how to talk through social determinants of health in a more common, eloquent way. Melissa probably knows, like, I think we need to tap into behavior and communications kind of mechanisms to make it relatable so that it's, oh, for education, it's the meals programs when we're not in schools, or I'm just making, I'm making leaps here. I would love to see, like Sarah, organizations like yours kind of be a part of like, how do we talk about it in other sectors? And how then do we also, I'm a real big fan of like, what are the top 3 things like the incoming Department of Labor Secretary should be doing so that they have somebody who's kind of positioned to do it, right? So that would be like my advice. And at the same time, like, I think, how do we in the healthcare world that talk about this a lot, how do we translate this so that it's not so wonky? Because I've had people say to me like, what do you mean you're going to measure loneliness? Like what does that have to do with like diabetes, And so we kind of have to get around that.
Good. Well, we got a few more questions and we want to try to get them in before the time is finished at 1:30. Nicole Truitt, who is with United Healthcare, raises a question about the instability in the health system that's resulted from COVID-19, and in particular FQHCs that you know very well, because Kavita, in terms of what impact that will have on our ability to address social determinants of health. Nicole says that FQHCs in particular fill a critical role in identifying social needs and connecting with resources, providing services, and so on. Are there policy or advocacy efforts needed to address the instability that is affecting these organizations that can really help in the social determinants area?
We know it is kind of interesting how sometimes out of chaos comes improvement or solutions. Yeah. What caused the stress on the healthcare system first, obviously, was the COVID itself, but then it was the precipitous drop in decline in utilization because people were afraid to go to any healthcare institution. And so everybody who was fee-for-service dependent took a big hit in February, March, April. And it's just now was getting closer to normal. And now, of course, it's probably like to turn back down. But I would just observe the solution, therefore, is to move away from fee-for-service faster than we were before, right? And what I've found heartening is primary care. I'm part of a group that's trying to help primary care in Virginia. And I'll just say they are way more open to non-fee-for-service payment than they were before. And I think that's been shown in a number of surveys around the country, not uniformly, but it's definitely way bigger than it was. So I would say, let's move toward value-based care and have less fee-for-service. And that will build in a shock absorber for the system that we didn't have this time.
Good. I'll just mention that Michael McKnight, who's with the Green and Healthy Homes Initiative, just makes a point about the challenge very often of getting some of the social service agencies to work carefully with healthcare, and sometimes that's capacity. I think sometimes it's also a trust issue. I have to editorialize there. And he mentions that New York ran boot camps designed to really build capacity for the social service providers to be involved. So I think it's an important point that we do have partners that are going to be necessary that have less experience and less trust in coming together. And that's clearly an issue to deal with. Kathy Stack asks, what is the state of evidence regarding the return on investment in addressing social determinants? Are there approaches, interventions that have solid evidence that yield savings or contain costs? Is there a pipeline of studies in this area? I would mention that there is an organization at the University of California, San Francisco called Siren that actually does a tremendous job cataloging research in this area. And the research has been expanding sharply over the last several years. If you just do a count of articles that even mention social determinants of health, it's going up geometrically. So there's a lot going on in this area. I don't know if any of you have any other thoughts on that, specifically where you see the best evidence for social determinants for a sector having an important role in health. Maybe Melissa, you might want to comment on that.
Sure. I mean, I would agree with what you just said, that I do think that there has been kind of an explosion of research and interest in trying to understand whether there is ROI in investing in social determinants. And I think the challenge here is that it is, there is no silver bullet, for every intervention that perhaps tends to be very local or even might be more regional in scope. One of the challenges that folks have faced is that it is hard often to scale them or to replicate them in different areas because everything is so localized. And so, while there has been a lot of evidence that has started to generate about perhaps, how providing housing to chronically homeless individuals, improve their health outcomes and/or, reduce their use of the ED, there are also, limitations on some of the research that has been shown. And one thing that I, have been reflecting on as I've been thinking about this question kind of broadly is a point that I saw in a summary report. The House Committee on Ways and Means convened a task force on rural and underserved community health over the past year or so, and they did an RFI recently requesting feedback on what they can through Congress kind of legislate and help to advance with respect to health disparities and social determinants. And in reading through the summary of the report, there's a lot of good evidence and examples in there, but their key kind of takeaway is, I'll read it to you, that although the RFI specifically requested submissions focused on examples of best practices and lessons learned, the submissions provided to the committee offer a few concrete data-driven solutions, and even those that were put forth appeared limited by questions of their scalability. Perhaps this gap in data access submissions is a reflection of the truth that silver bullet policies do not exist when attempting to address this phenomena that are varied, intertwined, and have historic roots going back hundreds of years. So just kind of, I thought that nicely encapsulated the fact that this is a complex area, and while there is a lot of research being undertaken and attempts to pilot different interventions across the country, it is going to kind of be an ongoing challenge moving forward.
Yeah, I would agree with everything Melissa said and in spades, but I would also just add, it seems to me a general way to characterize the literature is there are examples, housing, transportation, food, that do indeed save money, but for very well-defined populations, not in general. Mm-hmm. So this notion that somehow we're going to move dollars from healthcare to social and everybody's going to be rich, not going to happen. Okay, so forget that. But that doesn't mean it's not worth doing. It doesn't mean it's not worth doing both for those populations where we know we can save enough money to pay for that particular intervention, but it's still worth doing if it actually improves the health of different people. So I would just say, let's hold social determinant investments to the same standard we hold for cancer drugs or for that matter, COVID drugs. We don't ask for COVID to be free. We ask for COVID drugs to be worth the value we put on them. And that's how we should think about these investments as well.
Any other comments on that? Good. Well, we're getting close to our bewitching hour. And I'm just going to give you a heads up, the panelists. I'm going to ask you one quick question at the end before I just take maybe a couple of questions if we have time. And that is, if you actually got President-elect Biden, Mitch McConnell, Nancy Pelosi, and maybe Kamala Harris, who might be the presiding officer of the and calling the shots in the Senate, what would be maybe the two top priorities with regard to social determinants that you'd ask them to make sure that they pick up? So I'll give you a few seconds to think about that, and just allude to a couple of last questions and comments that we have, and we just have time for. Tamar Bauer, who's with Project Evident that I actually mentioned earlier, who asks, are there specific opportunities to build on some of the pilots that have been approved by CMS and other agencies in this area? And she says, coming from the perspective of having worked to create the Nurse Family Partnership Pay for Success project in Medicaid that you might be familiar with in South Carolina. So are there any particular gems out there you think that really need to be built on? I think Len mentioned North Carolina. Are there any others that spring to mind?
Well, the federal one I'd pick up on is Accountable Communities for Health. But what they want to do, what you need to do, is actually pay for services. What they did was track and refer, but not pay for services. And so that did not actually improve in people's health. But I think it's fair to say those backbone organizations that pull together their resources and assets in a given community to focus on screening and referral, if you gave them a proper amount of money, you could do a whole lot of good really fast in I don't know, 20 places in the United States.
Any other thoughts on that? Well, let me just, before I ask you your quick round question, lightning round question, I just noticed that pardon if I don't pronounce this correctly, Fessa Waldu, who is with MedStar, just makes the point that health and social service providers use different electronic systems, and we certainly have to address the challenge of using these different systems if we're going to see some success. So let me just end with my lightning round question about if you got the leaders in Congress and the administration together and were able to get 10 minutes of their time and told them that there are two takeaways that they really should focus on. What do you think they should be? Melissa?
Oh, you're making me go first. Well, it's a challenging one because I think that, you know, first of all, getting all of them in a room to agree on any one thing. I don't envy that fifth or sixth person in that room. But if I were to be that person, I think to a lot of the conversation that we had today, a lot of, where I think this policy can move forward is kind of within the gaps that exist within these programs and services to date. And I think a lot of the efforts that we've all been talking about have been, efforts to kind of build kind of connections between various types of entities, cross-sector, et cetera. And so I think, the number one and two thing that I would advocate for is really trying to expand upon examples where that has worked well, and really making that a focus of both the administration as well as the way that Congress is thinking about, writing legislation and advancing policies. Because the more that we just kind of continue to build upon siloed programs and services and structures, et cetera, the more challenging it just is going to continue to be as we move forward. And we need to be thinking much more holistically. And I know that's really difficult for Congress and the administration to do when you're moving on short time frames. But I do think it would be the best over the long term.
Okay. Len, what are your magic answers that you want them to pick up on?
Well, you said I could have two. So
okay.
Number one, data, force everybody to report everything. Number two, I think it's fair to say, I'll just, see Melissa's put forward and raise it a notch. I think there should be a White House level task force on whole person care, social determinants of health, every agency, let Congress be part of it, And first thing you do is you let Pam Brown and people like her from the local level come and tell these people what they should be allowed to do today. First, you want to figure out what permissions can we grant today to let the Pam Browns of the world go make life better. Number two, have that agency task force require every agency to come with legislation that would enable the braiding and blending to happen in a more efficient way. That's what you got to do.
Great, great, both of you. What about Kavita? What would make life better for you?
Yeah, lots of
things.
things could make life better for me right now. What I'll just to build on Len, I think you need to elevate it to kind of the level of the White House. And then I guess I would say, knowing Len understands and Melissa understands that if you want anything to happen, you put it at OMB. So it would be great to have kind of the White House level so that you can have a way to convene and talk to people at state and local agencies, state and local levels, the real world, so to speak. But I would argue, like Len, let's get a pad in there who's that's it. That's all they do is focus, instead of the way we do the pads for health and this, right? I mean, imagine if you could add a pad for determinants. Boom, right? I mean, then, because if there's one thing I've learned, it's like, he or she who controls the money, controls like the policies.
Attention.
And that's kind of a great place to put a human who could have an incredible impact.
Right. Thank you all. All very good ideas, and we'll pass them on. Well, I want to thank the panelists very much for taking part in this very lively conversation. I want to thank also our back office team here, Nihat Sharif, Tim Higashi, and Ed Berkey at Brookings, who made all the magic happen behind the scenes. I really appreciate that. And I want to thank everybody that tuned in for this. And I hope you all found it really helpful. It was a very lively, wide-ranging conversation. And as I said, there will be a link to this sent to you, all of you that registered. So you will be able to go back and look at some of the things that maybe you didn't hear in much detail. So that will go out to all of you. And thank you all for being a part of this. Have a great day. And I think we can look forward to some important advances in social determinants and the healthcare of our country. Thank you again.